walking hand in hand. Now, this particular session is on optimizing patient satisfaction post-cataract surgery. So, in this session, we will be having two speakers talking on the same topic. And these two speakers will be one male and one female ophthalmologist. The theme was walking hand in hand. So we will have two experts, of course, not necessarily of opposite gender, by the process of walking hand in hand, we have made it in this way. So, and we will have each topic to be discussed by our expert panel. So not wasting much time, I would like to go ahead with our intro video. Our chairpersons, I would like to call upon our chairpersons, Dr. Partho Biswas and Dr. Namrata Sharma, but unfortunately they are not yet here. But the time of the session has already approached, so I think we should not waste our time and start on. Yeah, and we have to call upon our panelists also. Dr. Rohit Shetty, sir. Dr. Anybody else is here? Nobody else is here. I don't see. Yeah, Rohit Om Prakash, sir. And nobody else I see. Oh, Dr. Srini is there. Come in front, Srini. Dr. Chaitra will be a little late, and Dr. Manpreet, don't see. Dr. Sujata Mohan ma'am is also not here. Sir, should we go ahead with the session? I think so. We will start on, and as people join, we can. Okay, the first topic for the day is by Dr. Vaishali. Vaishali, is Dr. Nishant there? Okay. I'll start the intro video. By the time if Nishant drops in, then we will go with your topic or we'll go to the other. Just start on with the intro video. Sir? Topic of today is the prelims for a crisp and comfortable monovision, and walking hand in hand in it is Dr. Vaishali and Dr. Nishant. Both of them are very expert surgeons, I would say, and being in the same LDP group, so I think they'll do a great job. Please come over, whoever wants to come first. I would request the speakers to please limit your speak within 4 minutes so that we don't delay, okay? And we have some discussions and interactions. Sure. Thank you. A very important person has not been introduced, and she is Dr. Priyam Biswas, who is going to play a very important role as a chronographer today.
So good afternoon, everyone. At the outset, I'd like to thank my dear friend, Dr. Sudipta, for this opportunity, and I'm extra glad that I'm walking hand in hand with my dear friend Nishant. So here I go without wasting much time. So what is monovision? I guess I thought there might be few PGs. So just basically it is the adjustment for one eye for near and the other eye for distance. And so this is what was, just 1 second. So as you see that if you focus on the, with one eye you are focusing the trees and the bungalows, and with for the near vision if you are focusing the child, so you, together you get a crisp vision with both your eyes. So pseudophakic monovision, we are all talking about post-operative things, and here we are all cataract surgeons. Doing pseudophakic is a type of monovision used to create the post-operative presbyopia by a programmed refractive error from biometric calculations. So perfection is expected by many, and more so by our patients. Every time we try to do good surgery, but the expectations of our patients are more and beyond. And in our quest to achieve all that, we've gone from being just phaco or surgeons to phaco refractive surgeons, giving the optimal vision to our patients. And they demand spectacle-free post-operatively. So can this be achieved? So I'm here a proponent of an SICS and a monofocal lenses. So is it possible? Yeah, let's find out. So the selection of the patient is more important. As being a professor, I have to tell my PGs also. So initially, which patients you have to select for your first cataract, and also for your first SICS and for your phacos. So selection of patient is very important. So also for this theme, because patients have to understand that some visual functions like stereopsis and contrast sensitivity and visual fields can be reduced if you focus on one eye, and for distance, and one eye for the near. So demerits of multifocal IOLs like decreased accommodative capacity, increased glares and halos, and night vision can be a problem with few patients who do not adjust to multifocals. So surgeons often select patients who not only have a strong desire to be free of glasses after surgery, but also fully understand that monovision design and its drawbacks. So here, if you have an other eye, good pseudophakia with distant vision clarity, and what do you exclude? A strong ocular dominance. Those who are more than 60, I would say is 70 plus, people with small pupillary diameter, corneal astigmatism more than 1.5. So don't do that. And those who desire that to have a totally spectacle-free vision. So what is traditional in where the dominant eye is corrected for the distance, but it can be a cross monovision when there is a design called as the dominant eye is corrected for the near vision, and the non-dominated is for the distance. And hybrid monovision is when we implant a monofocal IOL in the dominant eye and a diffractive multifocal in a non-dominant eye. So just a few words about SICS. The wound construction is very important, and I would, for lack of, yes, so this is a smart SICS technique popularized by Dr. Rajiv Raut, where without the, just because of the proper, this is K2K, that is keratometer to kappa reading. With this, we have an exact, we are aware of where to make the exact incision so that there is, and the proper capsule rhexis is needed, and then because of the proper incision which is guided by the keratometry. So I'll skip this. So to conclude things which seem, so with the monofocal IOLs also, it is possible for a patient to have a spectacle-free and good, great distant vision as well as great near vision as well. So things, with the help of monofocal IOLs, we can be spectacle-free. Thank you so much. Just the last slide that, okay, so you, with the graying of hair also, it's not necessary that you have used a lot of specs.
That was an excellent talk, and working hand in hand is Dr. Nishant Mahadevan. Yeah, no, not.
Yeah, good afternoon, respected dignitaries on the stage, and Vaishali for giving this amazing talk, and Sudipta for inviting me. It's so nice to see my LDP people, Srini sir also in the crowd. So here I go. Thank you so much, Vaishali, for your detailed theory. But yes, we all know that theory is something what we learn just to get marks. And practicality is what we need to please the patient. I'm sure that we cannot impress a patient with theory. I think you all can see that there's only one person who's standing outside the crowd. I mean, we are all together supposed to be. So she always wants to be someone who's someone different, who does something really good and something always different from the rest of us. So I'm sure that with the theory, it is given that same thing about what an IOL is. I'm not going to go in detail. We all know that the types of IOL. What I was supposed to do is how to achieve the monovision in phaco. And to do that, apart from what she said about the dominant and the non-dominant eye, all of us should have a perfect keratometry axial length and the perfect formula to decide the IOL which we are going to put. Because we know that even before we decide that we are going to give a different vision for the other eye, there should be an emmetropia on the eye we operate. She goes to whatever level to show that I am the boss. So yes, we know that I'll be stepped upon also, but I'll try my best to make sure that I try to prove her wrong. So what are the difference between SICS monovision and phaco monovision? One, she actually showed a large incision. We all know that the SIA, we almost keep it like if it is less than 2.8 and if it is near the limbus is what we call it as the SIA is neutral. And I'm not sure that whether she can calculate an SIA to decide on the astigmatism, but in phaco, I'm sure that we know our SIAs as well as long as we are doing it less than 2.8. And there are no toric lenses in SICS, whereas I'm sure that the debate on the toric lenses will also be decided. But as such, phaco you do, there is definitely something you can do on the toric lenses. With the advancement in technology, we know that FLAX, the laser-assisted treatment, you can also take care of the some amount of astigmatism, which is there and need not be toric induced. So to achieve monofocality, it is not only the spherical monofocality of 0.75 diopters, which we all know we have to keep it in the non-dominant, but to take care of the astigmatism as well. And yes, no longer I think patients prefer their eye to be injected because I'm sure that is what we all talk about is topical anesthesia and you get operated only with drops. So the tissue handling is also much less in phaco. So we all know that the importance of axial length measurement can be with different that's also very important. And as she showed a small video of SICS, this is just a small run through of a phaco, which is actually going to be the best method where we can decide on what type of monovision we can plan. So in terms of Rexwest, she mentioned that yes, you needed 5 to 5.5, but why? So that the lens stays in the center and you have an effective lens position. So I always prefer the stop and chop technique. You can see that the tissue handling is less and patient is operated only under topical drops. There is less amount of endothelial damage, and in terms of the comfort that the patient can get back to their routine life from the next day or the day after is something which I'm sure that they are going to enjoy. And you have these post-refractive, which you cannot do in SICS and plan a monovision. So post-refractive you should definitely take care of in the ASCRS calculator. And what is my take-home message? I think there is no other take-home message. There's only one message, that do phaco and then try to do a monovision and not SICS. Thank you. She's a wonderful person. Thanks, Vaishali.
That was a very good presentation by Nishant and Vaishali. And now I would like our expert panel to.
I would like to congratulate both of them for coming out with an excellent presentation. Everybody has one's own perspective. Monovision, yes, it was very much there in Europe. In Europe, surgeons used to, go in for monovision. But in my practice, basically, I really do not go in for monovision because, the patient's stereopsis, as you said, is a big issue with, that. And then the contrast is also a very important factor. Micro monovision, yes, to some bit, but then you have to explain to the patient, and one is not sure because the patient is always doing like this. So that is a big hassle. But the patient has, as she's rightly said, the patient has to be rightly educated about it. And that's the most important thing. But still, I'm not sure, even after educating, whether monovision will remain or we can go a step towards micro monovision. to some extent. Dr. Sujata, what would you like to add?
Actually, I didn't hear the first portion of the talk, and I heard only
So
Nishant.
she was propagating about monovision. She did imply that there are, some shortcomings with it. But she said that there are, of contrast sensitivity, depth and everything.
Personally, I don't like monovision. I feel the quality of vision that you get with good distant vision, you can always give them glasses for reading. I mean, they know, but they cannot go either for multifocal or trifocal or whatever it is, because monovision, it has its limitations. You cannot use it all the time. At some point of time, you have to pick up the glasses for distance as well as for near. So I would like to give a crystal clear distant vision. I would be happy with it. I don't know who spoke on what. So, okay.
Dr. Anurag, in your practice, what do you do? Yeah, please. You go till the way of micro, or you...
I strictly do not practice monovision at all for any IOLs. I think they had divided their topic into monovision in SICS and monovision in phaco. So that was, it sounded like some sort of a debate. Just let me clarify. In the next segment, me and my co-presenter would be on the same page. We would not be debating it out. We are just going to speak about different segments of the same topic. So answering your question, sir, I never ever practice monovision. And to me, it actually doesn't solve the purpose at all. I mean, since I'm a pediatric ophthalmologist as well, I understand the importance of binocular single vision, and I would like to have BSP given to each of my patients, both for distance and near, and the intermediate too. So both eyes working together, hand in hand, just to justify the name of this session. So monovision is something I don't practice, and in fact, it's an interesting observation that nowadays, even with the few enhanced monofocals that have come to the market, if you are rendering them slight myopic by 0.5, they are counterproductive. They are not working as well as they should. So, in one sentence, I don't practice this, and I don't believe in this.
Your thoughts, sir?
Basically, I agree with all. I don't practice monovision, and that's it.
Okay, so can we just move on to our next topic?
Yeah,
Just before we move on to our next topic, the tale of Torex by two very, I would say, not veteran, very young experts, Dr. Anurag Mishra and Dr. Swati Agarwal. Can we just hand over to Dr. Vaishali?
I think his aura is such that despite being young, he's...
Yes, he's an expert. So can we, sir, can I request Dr. Rohit to please hand over a token of appreciation to Dr. Vaishali and Dr. Nishant, and
I'm happy you're hiding me from the crowd.
your chance is coming. All over to you.
To you from a different angle. Thank you, Sudipta. Good afternoon, ladies and gentlemen. Greetings and regards from the land of Lord Jagannath. So my co-presenter would be speaking on how to optimize the toric outcomes, but I'm going to address to something that you might not have heard in many conferences, meetings being discussed. Why do we need the assistance or services of a toric IOL? The why of it. Let's get on to that. This is a post-operative refraction of a patient, a +1D sphere with a -2D cylinder at 180 degrees. What does it tell you? This is a post-operative refraction of a patient. What does it tell you? It tells you that a toric was demanded, was required, and we did not give it. Either, or we have implanted a toric, the patient needed a toric, and it has rotated by more than 30 degrees. Yeah. We'll take the second possibility under the carpet first and concentrate on the first. What is the spherical equivalence in this case? It's zero. Isn't it zero? Yeah. Right. So if you look at the biometry report of any optical biometer for a particular patient, this is what you have on the right-hand side, the spherical equivalence. Okay? What does the spherical equivalence mean? What it means is it projects the light on a circle of least confusion which is acceptable to the patient. Does not necessarily mean that the vision will be crystal clear. It just focuses on that circle, which is a circle of least confusion, okay, which is acceptable to the patient. We cannot have a cylinder without a sphere. We can have a sphere without a cylinder. We cannot have a cylinder without a sphere. So if a patient has a 0.75 cylinder at 180, what it means is he has a plus 0.75 sphere at 180. Or, putting it another way, 0.75 sphere at 90, 1.5 cylinder on the opposite axis. That's what it effectively means. This patient came to me, one eye operated, the right eye has been operated already, +1 with a -1.5 cylinder. Again, coming back to the spherical equivalence. What's the spherical equivalence in this case? 0.25. Isn't it 0.25? Should be perfectly acceptable to the patient. The other eye needs to be operated, right? Now, when I subjected this patient to the findings on an eye trace, now in here, if you look at this, these symbols are, there is a cross on the glass, which means both the sphere and the cylinder are uncorrected. The next segment will come when the sphere is corrected and cylinder is uncorrected. And finally, you have the final outcome. All right? Now, this patient with a 0.25 spherical equivalence, when was subjected to the eye trace, look at the MTF curves. They are doing miserably bad. All cornea, internal plane, everywhere it is bad. Now we correct the sphere and just put the patient on cylinders. The internal MTF improves somewhat, but the corneal MTF still remains low in that critical square. When we correct him fully, the same patient who had a 0.25 spherical equivalence, the moment we correct it fully, all the MTF curves improve. It will be further explained in the following slides. This is with both sphere and cylinder uncorrected, same patient. Look at the DLI, look at the E. How blurred or how distorted does it look? With the sphere corrected, it improves ever so slightly. With full correction, it improves massively, and the DLI score is a perfect 10 on 10. This is the reason why even with a spherical equivalence as low as 0.25, when there is a demand of torics, you have to give it a toric. All right? Now, to split and not show a spherical equivalence, to split it into the sphere, absolute sphere, and absolute cylinder, there's only one software which can do it, and that's called a Holiday IOL consultation software. Unfortunately, it is incorporated only in machines like the Varion and the Argos. So if you don't have access to these machines, you can still do a pretty good job. Just put your calculations on the Barrett's toric calculator. Let Barrett's toric calculator be your primary calculator, not the Barrett's Universal 2. That will give you the idea, fair bit of idea, whether the patient needs toric or not. And believe me, if you're not giving toric, the services of a toric in a patient who needs that, and just depending on the spherical equivalence you're putting in a monofocal non-toric IOL, this is what the patient is going to land up in, and the quality of vision is something that the patient would never ever be happy with. Thank you so much.
Excellent talk. Now, Swati, with the same topic.
I finished well within time too.
Yeah.
Yes,
Thank you
thank
for
you for that.
Do I need to stay here or?
No, please come, you can come down and sit. We will have the discussion after Swati's topic.
Okay, so Tale of Torics. I'm Dr. Swati Agarwal from Kolkata, and I would be speaking on optimizing outcomes. Well, so I would say optimize the chakra of actions, pre-operative, intraoperative, post-operative. Accuracy with precision at all levels should be targeted. Pre-operative evaluation is the key. Evaluate for irregular astigmatism, dry eye, calculate the keratometry readings, need to put all the readings in Barrett's toric calculator, we would see. So what about the dry eye assessment? Well, consistency is the key. Multiple readings needs to be taken. Discontinue contact lens wear. If there is an inconsistency in the readings, treat dry eye before remeasurements. So the picture on the right shows for the right eye, no drop was instilled and the cylinder powers are correlating. But for the left eye, since a drop was instilled, the powers are not correlating. Now, put all your data, all your measurements on the Barrett's toric calculator, because on the left-hand picture shows 1.5 of SIL, and on the Barrett's it shows 2.16 because it's also incorporating the PCA. Now, this study shows that integrated K method is the best way of calculating your K reading because this is more accurate and precise than other methods and should be taken from multiple devices. Coming to preoperative marking techniques, could be slit lamp bubble marking, freehand which can be confirmed with the smartphone app, and image guided systems like with the visual measurement unit or the Callisto. So ink marking in the theater, this has to be done on the dry eye, dry cornea, and the Mendes ring in the left hand and the axis marker in the right hand, and just mark once. There should not be any double marks. With the digital overlay, it also shows us the capsular excess margin and the various registration has to be done, and the digital overlay is there, which is a live image. And thereafter, the implantation can be done as per the axis. So digital image guidance delivers better outcomes than slit lamp assisted and other conventional marking ink techniques in terms of astigmatism. We've done a study of smartphone assisted versus the image guided, and we found equal results. And the femtosecond laser marking can also be done. Over here we can see that after the Mendes ring, we're just correlating with after application of the Mendes ring and the axis marker. Just below the axis mark, we can see a faint glow. So that is with the femtosecond laser, it has been done. And we found that this also correlates well. So intraoperative wavefront aberrometry can be done, but this also estimates the ELP. So what are the pearls to minimize IOL rotation? Well, optimum rexus size should be targeted and a concentric overlap with the optic of the IOL, wash behind the IOL, and at the last tap the IOL so that it stays in contact with the PC. Do not underfill or overfill the eye. Do not polish the anterior chamber because that helps in the tachiness. Give a CTR if the patient is a myope. Minimize activity of the patient in the post-operative period because of maximum rotation happens in the first hour and the first 24 hours. Correct dry eye atopy as dropping may lead to rotation from the poor quality of vision. So now, whatever the patient asks for, do oblige, try to oblige, because if the patient is asking for flax with EDOF toric, do give. There was a claustrophobic patient which had to be taken under GA. We gave torics for the same patient. Now, 82-year-old lady with diabetic macular edema, well, that can be taken up for torics. A patient of IFAS or intravitreal injections. Well, what I meant by showing these cases, we can explore possibilities, and my take-home message would be, believe in the available instrument, work on accuracy, technologies for mankind, and there should be a broad inclusion criteria for torics. Thank you so much.
Excellent presentation. I think there's so much which has been added by both the speakers. In our practice also, what we are doing is we are punching in all patients on a toric IOL calculator. And even with 0.24, more so if the patient happens to be against the rule, it comes. So I fully believe that torics have made a difference, and we should not shy. There should not be any limit, the lower limit or the upper limit. Anything which the toric Barrett toric calculator picks up, a toric IOL should be implanted, definitely by all means. And in all these patients, we should not rush to decide about the toric IOLs. We have to give the tear film and everything the time to stabilize, and then only we should go ahead with the toric implantation. Markerless has added, makes life so much easier, makes life faster, and it basically makes the transition very smooth. If 30% of your patients or 35% of your patients have a toric IOL, which comes with the calculations, you do not feel any hassle about it. Dr. Sujata?
I just would like to emphasize, like once you see the patient has a small cylinder, you have to do a topography, you have to do an eye trace. So you make sure that whatever your readings you're getting is perfectly all right, and also look at the ocular surface like Dr. Rohit said. So these are some of the very important things that we should do pre-operatively to make sure that you're catching the cylinder. And for me, the cutoff is 0.75. For not, I don't go down to 0.25. Like Sir said, I do about 0.75. So anything 0.75 and above, I would definitely go for a toric. And like what she mentioned, would like to make the patient lie down at least for a couple of hours in the hospital.
Very
Because
important.
nowadays, everybody wants to go out.
Yeah.
No patch, nothing, so we just want to go out. But we have to tell them to lie down for 2 hours and then go home also and take rest only for the first 24 hours. And hopefully it should not rotate. And most of these lenses which we are using now, the rotation rate is very, very less, but still we have to keep it in the back of our minds, because ultimately the patient is paid for a premium lens, and then 1 week post-op he comes with a cylinder, he's going to be very unhappy.
I think in counseling, we should give a passing reference that we might have to, rotate. Yeah, I think that should be an obligatory and mandatory thing in the counseling. Dr. Anurag, would you like to add something?
So first of all, big an apology. I don't have enough beds in the hospital to ask my patients to lie down for 2 hours, considering the number of surgeries that I handle every day. There's nothing to boast in this. I'm just saying that I'm short of space in the hospital. And personally speaking, I have never felt the necessity of that. Talking about the brand of files, as ma'am's rightly mentioned, that we use nowadays. If we are not leaving any lubricating material inside the bag, like the visco, then perhaps and we have ensured that it's a perfect shrink wrap. If the fit is proper, the alignment is proper, and the brand of the IOL is something we have trusted for years, there is perhaps no need for, because activity of the body does not necessarily extrapolate to the eye, and it doesn't cause rotation. That's the only thing that I would do differently.
I think they have done a study for that.
I know.
Yeah.
The rotation, so the study says out of the rotations that take place, maximum occurs in the first hour.
Yeah.
That's what the study says. The study does not say, if the rotation itself is likely to occur in 0.2% of the cases, then, the numbers are too minimal for us to, how would I put it, bind all the patients to the hospital's boundaries for a 2 hours period. In my practice, it is not practical, and honestly, I have not felt the necessity. We might have different.
We never used to do it, but now I don't want to mention the name of the lens, but when we're using IQ lenses, we never used to do it. But now, off late, because we've switched over to Technis platform, we ask them to lie down, because the IQ basically has some sort of bioadherence.
Yeah.
So the capsule adheres to it very quickly. So we didn't see much rotation. Even now, these lenses, we don't see any rotation, but because of the study, we started making the patient lie down.
You had mentioned about putting CTR in myopes. So what is your cutoff, wherein you put a CTR, and what are your indications for putting CTR in myopes, for that matter?
Yes, sir. So I had done an 8 diopter and a 11 diopter. Those cases I used a CTR.
Okay.
It's actually
I
a
did not
double-edged
use any
sword.
cutoff.
It's not something that is always productive for you. It can be counterproductive as well,
Yeah.
because it prevents the ring of Sommering formation,
Yeah.
because it stretches the equator. So you have to take a call. I think if the bag's doing fine in terms of its steadiness, then perhaps we don't need the services of a CTR. But if the bag's wobbly, when you find it out on the table, so all myopics as a rule, or even higher myopics as a rule, might not need it. But sometimes if the bag's not behaving the way you like it to, then maybe CTR can be
Yes,
put.
When the bag was too big, so theoretically we've learned to give a CTR, so I gave a CTR. Haven't done a study whether that would help or not.
Great. So
Thank
you
you.
would like.
Just one last question. This is for the learning of many people who do not have Pentacam handy. So how much of cylinder should you really consider when you are doing with a system which is not like IOL Master, you're doing a contact method. So how much of cylinder will be forgivable if you don't have a Pentacam always?
We are
So
not. I'm-
0.75
No, we are
or
not
not?
using Pentacam.
Okay, so you
The
go, no, but
all that you need to do is you put it on the Barrett toric
Yes.
calculator, which is
Yes.
available everywhere.
online, yes.
And your persons have to be ready for it.
Yes.
So,
This
you
is
know,
the message basically, sir. That is what.
Your assistants will try to dodge you by not doing it all, because this is a fitrat at least in North India. They don't. You have to reinforce it again and again. So, but toric calculator is freely available on
So that,
Yes,
that
so
should-
whatever method we are using for IOL calculation, it is always better to subject that to a toric calculator and find out and do a toric. Thank you so much. That was a very nice discussion. I request the next speakers, Dr. Siddhartha Ghosh and Dr. Hemant Chaudhary. And just before they start, token of appreciation to Dr. Anurag and Dr. Swati for the excellent presentation. I would request all of you to please come on stage and hand it over to them.
If I want a presenter view. अच्छा, कर दीजिए.
Surgeon.
Good afternoon, and thank you, Sudipta, for putting me here. And it's an excellent session. I see fairly good attendance here. Well, in the next few minutes, myself and Dr. Chaudhary is going to talk about decoding multifocals for optimal, patient satisfaction. This is something important, optimum patient satisfaction. And to go for the basics, actually currently cataract surgery with a monofocal IOL implantation is one of the most commonly performed surgical procedure in the world. But with the expanded use of screen devices, standard monofocal IOLs may no longer, serve the visual demands of population, which is increasingly interested in activities that would require good quality intermediate as well as near vision. So we have the choices of multifocal and EDOF lenses as well. Now, as the ASARS Cataract Clinical Committee states that not every currently available IOL is suitable for every patient. So we need to kind of understand the need of the patient, counsel them properly, and understand the visual needs of these patients, and then select the IOL. So this is something, a good guideline that has come up last year. Well, as for the IOL selections, we have a lot of choices. We need to look at the material, the platform, the optical design, and of course, as has been discussed for torics, IOL power calculation formulas need to be correctly chosen, like the Barrett's and Kane and whatever modifications we need to use. But let us remember that the right kind of model formula goes a long way for patients, for optimum outcome and patient satisfactions. I'll just take a few points, which are really important. The axial length, it should be, it's recommended that 22 to 27 are good to choose these kind of patients. And similarly, IOL powers 10 to 27 diopters. But yes, away from this range can also be done, but with little precaution. We need to take steps. We all know that longer axial length eyes are more prone to have retinal comorbidities, and the shorter eyes may have IOL tilt and also difficult to calculate the IOL power. So there are a lot of other cons associated with it. As for the keratometry, astigmatism correction, as we have just discussed about monofocals or as a whole torics, the higher the astigmatism correction we aim, the more, difficult it is if there is a small degree of rotation. So we need to be careful that in multifocals and as the topic suggests, optimum satisfaction would be brought about in, if we choose something, not a very high astigmatism correction, it should be a moderate correction. And of course, the AC depth again matters because the add power would also change. Well, as for the pupil size, the optimum range of pupil size that is recommended is, more than 2.8 mm in photopic condition and less than 6 in scotopic. There are a lot of contraindications. Some are relative, some are, absolute. So one thing we need to mention, as always, in the first talk, it was mentioned very rightly that dry eye disease needs to be treated first. And of course, keratoconus being an absolute contraindication, whereas, the previous history of any refractive surgery is just a relative contraindication. We need to look at the higher order aberration, the amount of it. If the RMS is less than 0.4 microns, maybe we can take up these cases. Well, I'll just end with a small video. It's a very interesting case. This is about a patient whom I had operated 10 years back. with Restore implanted in both eyes. In 22, he had come for a checkup, everything was fine. But last year, he came with this feature. The lens was, actually there was a spontaneous rupture of the posterior capsule 10 years later after surgery. So I thought this is something really different I have never encountered. I look at the literature, there are publications, and I was really surprised to see there are publications that spontaneous rupture can happen even after 10 years, or it has been reported even after 17 years. So in this case, if we talk about optimum outcomes, it's really a tricky situation to decide. Now, I discussed with the patient that we'll do vitrectomy and take out this lens and replace it with, because a multifocal lens is not available with a multi-piece design. So I said we'll put in a monofocal lens, multi-piece, if the anterior capsule, which looked clinically very adequate. But the patient was demanding, but he was really ready to take a lot of risks. He said, please try with the same lens. If I explained that this particular model is not made for sulcus fit, but he said, okay, if we have, as you said, a lot of complications may happen, we are ready. If this happens, we are ready for a second surgery. So he said, okay, that will be a third surgery, no problem. So we did a vitrectomy, and as you can see, a sulcus fit was done, and optic capture was done. For lack of time, I'll just show you that, well, it was done properly aligned, but then after an optic capture, it was pretty stable. And almost a year now, he had come for, checkup, and he's still maintaining 6, 9, and 6. The other eye is 6, 6, and 6, unaided. But yes, we are still apprehend there may be complications later, but he is very happy. Right. Thank you. So optimum outcome could be different in tricky situations. Each patient has to be, customized for their demand and need. Thank you.
Thank you, Dr. Siddhartha Ghosh. And now over to Dr. Hoymonti Chaudhary, the beauty with brains from Assam.
Thank you. At the very outset, I'd like to thank Dr. Sudipta Mitra for making me part of this very interesting session. And I'll be talking on decoding multifocal for optimum patient satisfaction. I do not have any financial interest in this presentation. So is it multifocal? Is it really overrated, or do we really need it? So my answer would be yes, because presbyopia is a pain, and nowadays we are seeing more and more cataracts in younger patients, so we just cannot let them be with a clean distant vision. 60 is the new 40. You really cannot stop someone from doing whatever he or she wants if he is just above 60. So you have to give him both a great distance and near vision. And yes, our life has been invaded by devices, so we need a near vision nice. So patient profile, of course, I'll not go into the details. You have to discuss about the gender, the personality, the type of needs and requirements, the occupation, and of course the astigmatism part has to be dealt with. So contraindications, as my co-speaker has already said, I would say these are the relative contraindications, because yes, fussy personality you should not pick up such a patient who will be very cranky. And retinal diseases and glaucoma, actually you need to rule out. I would not say this is an absolute contraindication, because we do give multifocal and injections also. And night driving, of course, someone who is very much into night driving, you rather not give a multifocal. So one very important and pertinent thing that you should do is you should counsel your counselors on a regular basis, and you need to tell them that they should tell the patients that they will have a greater range of vision rather than spectacle independence. The mantra should be under promise and over deliver. So in the pre-op workup, of course, you do not want to miss out on a retina like this, so an OCT macula comes in handy. Dry eye has already been talked about. If you have one of these devices, nothing like it, but if you do not have, then Sherma and ocular staining will be good enough. For keratometry and biometry, let me tell you, when I started my toric practice, I only had this keratometer, and it is good enough. But of course, if you have a second device to validate your astigmatism, it is great. If you have the luxury of using an IL master, great. Otherwise, immersion can also be good enough for you. So which lens to put? Of course, you'll have to decide whether you want to target e-metropia or the first myopia. And yes, I have a very low threshold for toric. As Madam said, I would also put in toric for anything above 0.75. So some of the surgical step, one is you will have to know your SIA. Then there has to be a perfectly sized rhexis, the middle video here, where I usually start and take the Purkinje image in the lens as the center of my rhexis, and then I'll take the guide of the pupillary border, which I'll try and keep my rhexis parallel to the pupillary border at all times, and the center would be the Purkinje image, and we target for 5 to 5.5 millimeter rhexis. And then the lens has to be a well-centered lens, and after you have centered the lens, and preferably the Purkinje image again should be in the center of the lens, then you need to have a complete visco wash, and it can be any brand of lens. There is nothing like, even our Indian products are doing extremely well now. So I would go and put in anything. There is nothing against Indian lens also. And then if you'd have done all these nicely, then there is ready, steady, and just shoot and go in and put a multifocal lens, and nothing can stop you from getting a result that you would like to have. Thank you very much for your kind attention.
Thank you, Hemanti, for your crisp presentation. And we have Dr. Praful with us as a panelist. Would you like to comment something on their presentation?
Sorry, I joined late, so I haven't gone through the whole PPT. Only one question from my side. Normally, we have a tendency to center the lens depending on the Purkinje image at the end of the surgery. But in one of the discussion panel, the discussion was now the patient is lying supine, so it's fine. So what about the patient? Immediately the patient starts mobilizing when he is standing and walking around. So if gravity is going to decenter the lens, or is it going to like that where you have positioned at the end of this procedure?
As we have discussion about this toric lens, ma'am was saying, usually the companies that we are using do not have so much of lens rotation, or even gravity doesn't. If you have a shrink wrap, the IOL displacement usually doesn't occur.
Sir.
Yeah. So the question, probably the RPCL need. The question was basically, why do you want to actually center it on table? Like, see, it's filling the back. So what is the point? And thing is, it's really not going to really matter. So you're see.
Yeah, absolutely. Yeah. I was just focusing on. Okay. Sorry. So if the first presentation was an excellent presentation, I think it showed dead bag syndrome. And this is the second, I have also seen one patient. So, and there's no, phimosis or, capsular rhexis, edge, nothing. It is happening. And I have seen one patient. And we are going to see, without any predisposing factor, you suddenly find that the anterior capsule the anterior capsule is as fine as ever. There is no fibrotic concentric at the rim. So, and there is no predisposition. And suddenly, because of the inferior part, it gives way the inferior capsule, and you find that the IOL has subluxated or dislocated. So this is an entity which is coming up, and as and how we move around, we are going to see more of these dead bag syndrome. In my practice, what we do is that whenever a patient comes, he has a dense cataract. And if there is an exclamation or anything or asterisk, we make the patient party to it, so that the patient should take a decision. Why to put yourself under pressure? If the patient believes that he wants to go in for a multifocal or a, so let it be his call. So, and I feel that despite our dissuading and telling the patients, those patients who are motivated, they still go ahead. But then your responsibility decreases a lot. One question which I would like the house to say, with patients with NPDR, do you go in for a...
Ideally, no, sir,
Yeah,
but then...
that's what I'm saying.
Ideally, no, but then...
And if the patient
Patient
says
is
he's ready,
persistent and
if the
is
patient...
ready to accept,
Yeah.
then... Sir, I would like to ask one...
Absolutely. Yeah. So this part has to be, you know, we explain, and there are once in a while patients who do say, yes, we want independence, so let's move on with
So
it.
in that case, what type of IOL would you choose? Not a trifocal, definitely.
Yeah. We
So
can
I
use the
would-
EDOF.
EDOF is better.
EDOF,
right.
EDOF IOLs can
EDOF
be.
are better.
Yeah,
So
better.
one question, because technology is advancing very fast. So I've experienced it myself, that's why I'm saying, EDOF IOL patient and then reads about something upgraded and comes up with no financial interest, with interest for synergy. So what would you do? Because I had a patient like this, and then after I did that synergy on insistence, after telling him that these are two different, the other eye he got dissatisfied. The second eye he was so satisfied. So the other eye, which he was having a bit myopic, I had to do it because of that. So now he had problems. Would you do something like that? Because this was, I burned my fingers in it.
You mean in one?
It was EDOF
EDOF.
already, and then the
EDOF
next
means
generation
it was
came
Vivity
in.
type or
It was a symphony. Then only
Okay.
symphony was there.
Yeah.
So when later on this other one came on, a synergy.
But then
so
you have to tell the patient that you
Yeah.
are doing, you know, what I feel is, what we are trying to do is, we are taking the onus on ourselves.
Yes, yeah, that's right.
I think we have to move on.
Counsel
We have to
more.
tell the patient, we have to make him party to it.
Yes.
Once you make the patient party to it, then you know and it has to be a written consent in the patient's, you know, handwriting that I'm getting this done at my own. And there are people around, you know, who would, I have seen surgeons around, they are not bothered about angle alpha, they are not bothered about scotopic, they are not bothered about anything. They are putting trifocals left, right and center. The only thing which they are telling the patient is, it's a new device, it will take time to adjust. And more or less after 6 months, with the neuroadaptation, quite a few patients, they adjust. But we should not go that far. But with proper selection criteria, we should, and with active patient involvement. In our practice, what we have done is we have kept the same, it's a financial matter, we have kept the same margin for everything. So the counselors, they don't go out of the way. So that makes life easy for you.
Thank you, sir. Very well discussed. Our next topic would be, I'll just give you the mic. The next topic I would ask Dr. Chandni and Dr. Debojit Ray to get ready. Yes, with IOL in tiny eyes. Yes, Siddhartha, please.
Actually, the patient is a CA, so he asked me an interesting question. Like, as I said, it's a spontaneous phenomenon. It can happen with anyone. He said, but you operated the other eye 3 months before this.
Yeah. Yes.
So how come this happened?
Yeah.
And the other eye is fine.
Yeah.
So I said, you should, because I always counsel the other eye can also have the same thing.
Yeah.
Right. So he said, how come your science doesn't explain that?
Yeah, absolutely.
He's happy otherwise. But then I also don't have an answer for that.
Yeah, absolutely.
No,
Absolutely.
similarly, when the patient in the someone in the family is very happy with multifocals.
Yeah.
So they want to come and get multifocal done, and then they keep complaining. So I think it's a lot of shared work that we have to do, and also the
Absolutely.
counselors.
Yeah.
That's the main.
It's a very interesting topic, so I'm very happy everybody is discussing. Anurag, 30 seconds, okay?
No, I just wanted to mention that since Dr. Siddharth had actually brought it to the sulcus, and somehow, I don't know how, but he got away with it. But the message, when we are calculating the power of a trifocal or a multifocal, the residual power should never be on the myopic side, and it should do nothing on the table to take it to the myopic side. If you're putting it in the sulcus, even with a proper anterior capsular capture, it can still have a myopic residual. The moment the patient turns myopic post-operatively, the halos are going to be very magnified on the fovea, and the patient's going to be very, very unhappy post-operatively. That's just one message I wanted to give.
I discussed all this with the patient.
Yeah. Please come. This is a very interesting topic, so we will keep on discussing. Just before we start on, to hand over the mementos, yeah, please, Hoymunti, Dr. Siddhartha Ghosh. We are thankful to Ajanta INX division for these mementos that they've arranged. Please come over, and a quick photograph. Think that way, as you take it. All over to you, two very young guns, and they are going to talk about the young eyes, the tiny eyes. Okay, all over to you.
A very good afternoon to the, hello, am I audible? Yes. Okay, a very good afternoon to the esteemed chairpersons and the lovely audience. So today, and thanks to the scientific committee and especially Dr. Sudipta for having us on this forum. After those technological flights, now it is time to land on the ground. Why I am telling this will be evident from my next couple of slides. I have no financial interest in this presentation. So why this topic? Pediatric cataract does not have a one-step solution. That is, on POD1, you are not going to get any type of magic. A growing eye presents unique management issues quite different from the adults. Refractive status and amblyopia considerations after surgery are most important aspects. Those impact long-term visual outcome of the child. Lifelong follow-up is an absolute necessity after surgery. There are limitations in utilizing latest technological advances in pediatric cataract surgery. Now, the age for surgery, this part I will skip for my co-speaker, Dr. Devjit Rai. And also the IOL power selection and refractive target, I will skip. Now, I will come to the special issues or the hurdles in pediatric cataract. What are those? First one is the amblyopia. It is most important part, amblyopia considerations. Why amblyopia occurs in pediatric cataract? First of all, this is due to delayed presentation. You can see the first picture. The boy came to me at 16 years of age with already the amblyopia set in. After surgery also, the corrected visual acuity was 6/18 only. Then I have so many patients who, after cataract surgery, did not come for the refractive corrections. So this is another cause of amblyopia even after a successful cataract surgery. And the complications are many times neglected. We have a huge experience of working on vision restoration surgeries in case of low vision kids. And we found, you won't believe, out of the 100 cases, 45 to 50% of cases were only the secondary complications of cataract surgery, not the neglected cataract. And compliance for amblyopia is a worldwide problem. Now, where the choice of IOL is concerned, single piece versus multi-piece, all of you know we prefer single piece, and multi-piece is generally for special situations where the capsular support is under question. Then SF-IOL, I have done a series of SF-IOL in children, and I generally prefer to do after the age of 5 years, and outcome and safety are quite satisfactory. Then about the premiums, well, about the premium IOLs, there are so many studies which show good outcome after the premium IOLs, especially the multifocals. But the limitations are, those studies are done on a very limited number of patients. The sample size was very less, and the maximum period of follow-up was 36 months. So, I don't think those are very reliable indices, and for pediatric cataract, we don't know how the eyes will behave, and we also don't know what will be the profession of the child. And lastly, the biometry is not always accurate. Even if we do it under anesthesia, the visual axis is generally not very accurate. So we cannot rely on the premium IOLs for pediatric cataract surgery. Now the follow-up, this is the most important part which I want to stress upon. The amblyopia therapy is very important. When the child comes to you, a thorough refraction with retinoscopy should be done, and thorough posterior and anterior segment evaluation is very much necessary. And so far as the myopic shift is concerned, we do sorry, I have only 2 slides more. So we do IOL exchange for only the cases where it is more than 4 diopter of myopia, and other long-term complications are to be addressed. And the role of examination under anesthesia cannot be denied. Now these are some complication managements. For lack of time, I will not show them in details. So these are some surgical management of the complications where we do membranectomy, IOL exchange, and IOL redialing. So lastly, the take-home messages are every pediatric cataract is a unique challenge. Adequate preoperative evaluation and decision-making are of utmost importance. Meticulous and protocolized surgical technique maximize the favorable outcome. Postoperative follow-up plays a most important role in long-term visual rehabilitation of the child. And growing eye may not behave as expected even with latest IOL technologies. And this is my last slide, and our aim should be wipe off this slide because this lady presented at 28 years of age with congenital cataract. And from our world and from our country, I should wipe off this type of cases. These are my references. Thank you.
Thank you, Chandni and Dr. Debojit. Okay.
Come and sit.
Good afternoon, everybody. At the outset, I should thank Dr. Sudipta Mitra for giving me this opportunity. So no financial interest. I will just focus on these points: the IOL implementation, this primary, secondary, IOL types, and IOL power selection and target refraction. Most challenging part of a pediatric cataract surgery. So primary for IOL implantation, most of us go for IOL implantation more than 2 years of age. Less than 2 years, increasing number of surgeons implanting. I have implanted IOL in 8 months of age. But less than 6 months, usually we don't go for it because of the complications. And for the IOL size, for 2 years or more, we usually give the adult size. For less than 2 years, we usually go for this white to white corneal, horizontal white to white corneal diameter, and give the overall diameter of the haptic 1 millimeter more, so that it can snugly fit into the sulcus. Secondary IOL implantation is also a safe and effective alternate. It's correct aphakia in contact lens and spectacle intolerant children. For this, also in case of traumatic cataract, in first we cannot go for IOL implantation. After the eye becomes quiet, we can go for secondary IOL implantation. Now, types of IOL, most of cases we go for hydrophilic acrylic single piece IOL. Multi-piece IOL sometimes we give. Multi-piece IOL also we can give when first we have done a lens aspiration and primary posterior capsulotomy, anterior vitrectomy, a small child. And then when the child grows and the anterior posterior capsule becomes so attached that we cannot separate them. So then in that case we can go for multi-piece IOL because we cannot give, we cannot put that, we cannot separate the anterior posterior capsule. And single piece should not be given in sulcus, especially in children. SF-IOL we also give for congenital lenticular subluxation in some cases, like in congenital rubella, when we go for total lensectomy and vitrectomy in later age. If we are sure that there is no viral infestation or something, we can go for secondary SF-IOL, or in case of traumatic cases. So advantage of hydrophobic IOL, their ability to inject through very small wound. The haptics unfold very slowly. So it can be given up even after the PPC is done, even in large PPC. it has got a very good memory. Where it is given, it stands there. It does not rotate. Lower rates of PCO and lower rates of IOL opacification. And most important for the children, less rate of postoperative inflammation. We usually don't give yellow-coated lens. We give white lens. These are few contraindications of IOL. Absolute are usually severe microcornea, microphthalmos. When the eye is too small, less than 9 millimeter diameter, horizontal white to white diameter, I usually don't go for this lens. And there are some relative contraindications. So most problematic is this IOL power selection and target diffraction. These are the problems with pediatric IOL power calculation. The axial length keratometry measure errors due to non-cooperation and fixation errors. And all the things are instruments designed for adult eyes. Target diffraction and myopic sheet is also causes a problem. So it is a practical difficulty. Lack of fixation under anesthesia may lead to inaccurate keratometry reading. Need for a handheld automated keratometer, which is not present in all the institutes. And we need a very good experienced biometry person who has the idea or knowledge or training for this pediatric biometry. Choosing the right formula of IOL power calculation is also a challenge because all the things, these are for adult formula. So it is not good for 2 to 17 years of age. In our institute, for cooperative child, for optical biometry, sorry. Okay. One second. So these are our postoperative refractive M. We usually go for moderate plus, not 0 or not high plus. And these are recommendations for IOL power selection. So for emmetropization, we mostly go for this Dahan and this one. And so take-home message is the IOL is the best choice for treating pediatric cataract. Selection of optimum power is multifactorial decision, and cataract surgery is but the one step on long road to visual rehabilitation, not the end of the journey. These are my references.
Thank you so much, Debojit. We welcome our chairperson, Dr. Partha Biswas, sir. In interest of time, before we go to the next topic, we'll take a question from one of our panelists who is also present, Dr. Manpreet.
So, for the esteemed panelist and chairperson, I have one question. What's your take on premium IOL in pediatric cases? It's a controversial topic even now. So what's your take on that?
For me, it's an absolute no. In pediatric age group, it's absolute no. And I think that's it.
Torics above the age of 7 or 8. And a few questions for you because you're from the premium institution. If the child is on the myopic side and between 2 to 5, do you do PCC or? And Dr. Chatra, from the retina perspective, would you advise?
Given the fact that they're still in the amniotic age group, so we would still prefer that it's done. And if the anterior-hyaloid face is intact, better not to do.
Yeah.
Can I just?
Most of them have a formed vitreous.
Yeah.
And the anterior-hyaloid face is intact, so you don't really need to do anything. You can just do a gentle, PC opening in the center. That's more than enough.
But then you are leaving behind the scaffold.
If you breach the anterior-hyaloid face, it becomes really messy. The inflammation becomes more. So unless you're very confident of doing a good anterior vitrectomy without any vitreous actually coming anterior, then
you're leaving, huh?
Because that keeps a barrier good enough.
Chaitra, carry on.
I was saying that's up to the neatness of the procedure. What I'm saying is, if you are doing a PCCC without doing a vitrectomy, the anterior hyaloid face remains as a scaffold, and the peripheral marginal epithelial cells can regrow and perform and actually produce a blockade or a blockade of the PPC opening very, very fast indeed. I mean, we are talking about a 2 to 5 years of age group. So in my opinion, if you're not going to do anything, don't do anything. If you're doing a PCCC, then you should be doing a knee vitrectomy associated with it.
And I would quite agree with this. And the plaque or the epithelial cell that grow over a hyaloid phase is much more difficult to YAG. than a PC which has opacified. Anyway, a PC which has opacified is really very difficult, so a membranectomy has to be done through the posterior route. But I think neatly done PCC and an anterior vitrectomy, just as much as is required.
What happens most often, of course, for you guys, it's okay because you'll be doing it very often. A lot of them tend to do such an incomplete job that we have to go and complete it.
Yeah.
It's very, very messy. They're speaking,
Yeah. Yeah.
Okay.
One just what
Question.
Chaitra said. Now, it was at one point of time that the manual capsulorhexis used to be done for the PCC. I still do it in my cases, but now it is easier, and people who are getting initiated to go by the vitrector after placing the lens in the bag and do a posterior capsulorhexis or a posterior capsular opening, and then an anterior vitrectomy, and then place the lens back.
Very practical points
last
discussed.
question, because this was missed. Dr. Manpreet, how often do you check the IOP of the patient because that is something which is the most neglected part?
There is indication to perform it earlier, and at that time we do suture removal and IOP. After that 3 months, then 6 monthly till I decide to implant an IL if I've left a phakic, or the child is old enough to allow a slit lamp
So
examination.
you subject the child to EUAs
Yeah. Yes, sir.
without any...
Serial EUAs, under mask.
Yeah, that's...
We do subject them to serial EUAs. Yeah.
This discussion is no, sir. This is such an interesting topic and so much to learn, but the time is limited. So just we go on to our next topic, and we quickly hand over the token of appreciation, ma'am. Sir, can you please come up? Dr. Praful is leaving for another session, so just hand over quick. Yeah. Yes, it's for you. One is for you. Yeah. Dr. Chaitra, you are not leaving in the next? Okay. Yeah. Yeah, and the participants of these topics, please come over. Yes, Dr. Chandni and Dr. Debojit. Yeah. Yeah, Chaitra, yeah, please come. Come in between, come in between. Have you started? Yeah. We go on to our next topic. Thank you so much, esteemed chairperson, our panelists, and my speakers, and the beautiful audience. Not wasting much time, my topic, bringing the smile back after post-operative surprises. I have no financial interest, so after we finish off a good IOL, and we still have the patient coming back to us repeatedly, then what do? We have learned a lot, but when a patient's post-operative refractive target is not achieved, and it can be due to a dominant switch, the patient is highly dissatisfied or is discomfort. Usually the correction we plan is lens-based or is IOL-based. But first we have to understand what is the actual miss and how big is the problem. Is not coming? Yes, there's an audio, yeah. But it's not playing, but I just went on. So before we draw any conclusion, we need to know how big is the miss and then deal with it accordingly. So identify the cause. A formal subjective refraction is always required instead of an auto refraction to know what is the refractive error. Do a dilated thorough examination to find if there are tight corneal sutures, are turned toric IOL or IOL in the sulcus, and deal with it. Sometimes simply a distended capsular bag due to retained viscoelastics can be a problem which we can remove just by capsulotomy. So dealing with simple things before we think big. A CME, this can also lead to a dissatisfaction in a patient, and this can be simply treated by assurance and treatment. Corneal scars or edema are a very important cause, need to deal with it. But this particular thing, biometry error or a wrong IOL choice always has to be documented and corrected forthwith, because this is a very important problem, and dealing with this, all of you have said, with different machines is very important. I won't go into details. We all know that dry eye is a very important problem, and dealing with 60 to 70% of the dissatisfied patients by simply treating and counseling may relieve them of their discomfort. Talking to the patient candidly may sometimes help without any intervention, but if you're not lucky with IOL tilt, opacity or dysphotopsia, what do? One method for the lens is an IOL exchange. This is possibly taken as early as possible until it is an opacified IOL. This is an opacified IOL. We use optimum viscoelastics to create a space between the IOL and then lifted it up from the optic haptic junction, because that is where it is least adherent. There are different methods of actually taking this IOL out. You can cut it through and through, or you can do a Dodic method where you can go 3/4 and take it out in an elongated fashion while the two pieces are still joined at the center by dialing it out in a clock and then an anti-clockwise direction. So this is a way how we do an IOL exchange. Sometimes we are lucky, we can put the IOL in the bag, but not always. We may induce astigmatism if we increase the wound, or there may be a PC rent or capsular damage. So there is another way how we can also deal with things. That can be a piggyback or an add-on IOL, which can be inserted in addition to the original IOL. And this was a patient who was a myopic patient, resulted in a hypermetropic post-operatively, and this is the IOL that's sitting in the bag with a good AC depth, with good AC count, stable refraction. This is very, very important that we should have a stable refraction before we decide to intervene. So this was taken up nearly 1.5 months later, and this is a piggyback IOL which is put in the sulcus. It's basically sulcofix, no financial interest, with 4 thin haptics which was put in the sulcus. And as you can see, like a phakic IOL, it has a indicator with a notch at the leading left haptic, and then this was tucked in the sulcus. Literature suggests that this is better than a piggyback, considering the chafing and the inter-IOL opacities. This is safe, predictable method. Advantages, we need only the effective refraction that we are getting. We do not need a biometry separately to deal with it. There are formulas, and this usually maintains a very good AC depth and good endothelial cell count. We have some studies in it. So the take-home message is, first of all, each case is different. So customize each case to the need of the patient, spend more chair time with them before surgery and also after surgery. Thank you so much for patient hearing, and over to my
Sudipta,
yes, sir.
the stalwarts of the next session have come.
Yes, sir. This is the last presentation, and Dr. Aishwarya will speak
Agree, sir.
in place of Dr.
Agree for the last
Ashok Nanda.
speaker.
Sir, that is why I finished it off before 4 minutes.
Dr. Ashok Grover has said yes. Go ahead. But keep it short.
Yes, yeah.
That will always happen, you know.
30 seconds for a photograph.
Good afternoon, everyone. Thank you to the scientific committee, and thank you, Dr. Sudipta, for letting me speak on behalf of Dr. Ashok Nanda. He was not able to come. So, bringing the smile back in post-operative surprises. So, Sudipta has made my life a lot more easier by telling most of the basic things. We cannot ignore the corneal surface. We cannot ignore the tear film. So, there are certain basic things we need to check in and rule out before we really think about intervening on the lens surface or on the corneal surface. So for refractive surprises, we can have lens-based corrections and cornea-based corrections. That is LASIK, PRK or LRI. And it's very important to distinguish whether we want to do a cornea-based correction or a lens-based correction, because for lens-based corrections, it is earlier, we intervene earlier, and cornea-based correction, we at least let the refraction settle for at least 3 months before thinking of any intervention. And before we do all this, it's very, very important to counsel the patient doubly, triply, how many times you can, because they have to be very realistic even after a second intervention. So they should not think that everything will go back to perfection after a second intervention. And we must be doubly sure about our evaluation, because sometimes not all these patients are your own patients. Sometimes they come back post-operatively from other surgeons. And then we must make the right decision for correction. So now eye trace makes our life very much simpler, because it helps us to distinguish, that's the only device that helps us to distinguish between what is the echoes due to reflections due to cornea and what is disturbance due to the lens. So it actually differentiates between the two. No other device can help us do that. That doesn't mean that people who don't have access to eye trace should not attempt it. So now let's take 3 case-based scenarios. The first case is the patient who had undergone an toric IOL implantation. Now we see that the patient is left with a residual of a 1.8 diopter sphere and a minus 1.12 diopter cylinder at 88 degrees. So what do we do? Like, is this a wrong choice of IOL, or is this an IOL rotation, or what is it? So do we go for a lens-based correction or a cornea-based correction? Now we see that this patient has some amount of lower order aberrations and a higher order aberrations. And then doing a toric alignment shows that when we have a 60, if we subjected the IOL to a 65-degree rotation, he would have a lot of reduction in the cylinder, but still he would be left with a 1.33 diopter sphere and a 0.05 diopter cylinder, which wouldn't help much. So in this case, instead of rotating the IOL, we have to go for a cornea-based procedure, and we have to go for a wavefront guided LASIK or a PRK, as the case may be. Now coming to the second case scenario. Here a patient with a mature cataract underwent a cataract surgery with a multifocal IOL implantation, which I would never do. I would of course do it if the patient is willing to take equal risk. Now we see that the patient is left with a refraction of a plus 3.5 and a minus 1 diopter cylinder. Now in this case you see the patient has quite a high amount of astigmatism. The coma and the trefoil is quite high. So in this case, if it would be so much simpler to just do a cornea-based procedure for a multifocal that is lying well settled inside the bag. But if in this case we were to do a cornea-based procedure, then it wouldn't help, because he still has a lot of higher order aberrations. So in that case, we would go for cornea-based procedure. Sorry. Now coming to third case scenario, here we have a case with a toric IOL implantation, and he still has a minus 1 diopter residual cylinder. Now coming to the aberrometry, we can see that the corneal aberrometry and the lens aberrometry are both equal. So in this case, if an alignment of just the corneal cylinder, realignment of the 12-degree rotation reduces the corneal cylinder and leaves the patient with just a minus 0.1 diopter sphere. Thank you.
Thank you, Dr. Aishwarya. So before we hand over to our next session, I just request 1 more minute. Sir, do you have to add anything?
No. Just a minute.
Walking
Second
hand.
case, we explanted the IOL.
Walking hand in hand is a great concept, Sudipta. So fantastic. Yes. On the topic, okay. I think let's leave it to the next session now. Thank you very much.
Sir, just a quick, we will just take a 1 minute to, not 30 seconds maybe, for a quick picture with the speakers and panelists. And sir, please come over and please bring, So, the speakers can be, sir, you can hand over to the speakers and then to each other. And we have a quick picture, yes.
You hand over, why don't you?
So you have to